Hello everybody and welcome back to the Your Go-To Doc YouTube channel. Today we're going to be talking about carpal tunnel syndrome, which is basically a pinched nerve in the wrist causing pain, numbness, tingling, and possibly weakness in the hand. We're going to talk about what carpal tunnel syndrome is, why it happens, what kind of symptoms you have, what your options are for treating it, including the surgery, and what to expect before, during, and after that surgery. So hang in there and stay tuned and watch on, and we will talk about carpal tunnel syndrome. So what is carpal tunnel syndrome? It is basically the pinching of the median nerve in the wrist. And that little tunnel, that's called the carpal tunnel, is a little space that the nerve runs through between the bones in the wrist behind the nerve and a very thick sheet of ligament in front of the nerve. If that space gets too narrow and the nerve gets pinched, you can get pain, numbness, and tingling in the first 3 digits of the hand and then half of the ring finger. So that would be the thumb, the index finger, the middle finger, and then the inside half of this finger here. Pretty pathognomonic for a pinched median nerve. It's very interesting how just half that ring finger gets numb in patients with carpal tunnel, and pretty much across the board. So as far as anatomy is concerned, even though there is some variability in where nerves supply areas of the body, that's pretty much the same for most people, almost all the people that I would see with carpal tunnel syndrome. So in addition to pain, numbness, and tingling in these 3 fingers and half the ring finger, you can also get pain in the wrist, pain in the palm of the hand here, and if it's really significant, you can get weakness in the muscles that bring the thumb and the pinky together, as well as worse symptoms at night. I'll explain a little later on why I think that happens. It's purely theory and conjecture, but it's the best reason I have for that. One interesting tidbit about carpal tunnel syndrome is that, unlike popular belief that it's mostly occurring in people who use their hands a lot, I have not found that to be the case. People that work in factories putting things together with their hands, yes, they can get carpal tunnel syndrome, but I would often see carpal tunnel syndrome in people that don't do anything like that kind of activity. And I would say it's about a 50-50 spread over people who use their hands a lot versus people who don't. Another interesting fact about carpal tunnel syndrome is it can occur temporarily in women who are pregnant. This sort of goes along with the lines of why I think it is often worse at night in patients that have this syndrome, because I think that carpal tunnel, if you are on the bell curve where you don't have a lot of room in there, but not tight enough to cause symptoms, something like pregnancy, which basically increases your weight throughout the entire body, can increase the soft tissue density in the area of the carpal tunnel and tip you over the edge into having symptoms. And that's why pregnant women who never had carpal tunnel syndrome before will get carpal tunnel syndrome during pregnancy, and then once they deliver the baby, lose a lot of that pregnancy weight, the symptoms go down or go away. I think that's also the case in patients who are not pregnant and men. If they gain a lot of weight, that weight is gained everywhere. So if you're already on the edge of being symptomatic in your carpal tunnel area, gaining that weight can tip you over the edge into getting symptoms. And then finally, why is it worse at night? My theory is that when you get horizontal and lie down in bed at night, your fluid shifts from your lower extremities into your upper body. That's why a lot of times when you get up in the morning, you feel puffy in the face. Why, if you jump out of bed and get in the car, you may have to adjust your rear view mirror because you're actually a little taller when you first wake up in the morning, because your discs in your spine rehydrate as the fluid shifts upward in your body and re-expand, so you could be slightly taller. So I think what happens is at night, the fluid kind of trickles up from your legs into your upper body, and if you're on the edge of having symptoms in your carpal tunnel, the tissues in there get a little more swollen, and all of a sudden your hand starts to go numb at night. The classic description of symptoms that patients will describe if they have carpal tunnel is, again, pain in the wrist, pain, numbness, and tingling in the first 3 fingers of the hand and half the ring finger, often worse at night. often worse with hand elevation, steering wheels, telephones, hair dryers, things like that. Often when it wakes the patient up at night, in the middle of the night, they'll shake their hand over the edge of the bed or hang their hand over the edge of the bed to make it feel better. And that's the typical description of symptoms for carpal tunnel. So how does a patient end up getting to see me for this problem? Usually what's going to happen is symptoms will gradually increase over time to the point where it's starting to interfere with their activities of daily living. Either they can't get a good night's sleep, or they can't drive, or it has something to do with their job or hobbies where that numbness in the hand starts to interfere with things. Or if it's allowed to go on long enough, they can actually start to get weakness in the fingers of the hand, and they may notice that the muscle on the thenar eminence of the hand, basically the bottom of the thumb here, will start to flatten out. And if they have carpal tunnel in one hand and not the other, and it gets bad enough, they can actually hold their hands out like this and see a difference in that muscle right here, which shrinks up in the hand that has carpal tunnel syndrome that's become severe. So they'll have the symptoms. They'll eventually probably tell their primary care doctor. Their primary care doctor will typically send them to a neurologist, and a neurologist will get something called a nerve conduction study. And that will document that not only is the nerve pinched, the median nerve, but it's actually, that test can locate where it is pinched. And they'll say there is a conduction block at the wrist. And that is pretty much pathognomonic for carpal tunnel syndrome. And I very much like, as a surgeon, to have an EMG test or nerve conduction study that confirms carpal tunnel. That raises my confidence level that if I unpinch that nerve, the patient's going to feel better. So that's usually how a patient will end up in my office for carpal tunnel syndrome symptoms. So before we talk about what I will say to the patient in their office visit, let's take a look at some pictures. So we're going to look at some diagrams of what the median nerve looks like as it runs through the carpal tunnel. They'll show some branches of that nerve which are relevant when we talk about the surgery, as well as the anatomy around that area, which is also relevant. And then we'll then jump over to what I tell the patient when they come into my office for their visit. So here we have a diagram or drawing of the hand. The picture on the left is the palm view of the hand. The picture on the right is a cross-section view. And here we see the median nerve traveling down the arm through the wrist area, through the carpal tunnel into the palm. You can see the carpal ligament covering the nerve. You can see the branches coming off the median nerve up here, going into that muscle of the thumb. That's the branch you got to be careful of when you're doing the surgery. There are variations in patients where this branch can come off lower, it can come off on the wrong side, etc., etc. I'd say in real life, the carpal ligament actually comes a little further down the hand here and maybe further down the wrist here. So this is a relatively minimalistic view of the carpal ligament. But basically you can see where a half inch incision right about here, slightly off to the pinky side of the midline, will allow you to avoid the area of the branches of the nerve. And then for the surgery, which I'll talk about in a little bit, you basically cut this ligament, and you make sure you cut it all the way down here where it usually goes and all the way up here where it usually goes. The cross-section picture of the hand shows the median nerve squashed between the bones of the wrist and the ligaments of the forearm muscles. The tendons of the forearm muscles, squashed between those and the carpal ligament, which is this thick sheet of connective tissue running from this wrist bone to this wrist bone. And you can see if this ligament gets too thick, or the tissues in here get too thick or swollen, that nerve's going to get basically crushed and give you symptoms. So this is a pretty good diagram of what the nerve looks like from the surgical approach and the cross-section approach. And then also as a side note, this shaded area is where you can get numbness and pain from that nerve being pinched, and I can also tell you that you get pain in the wrist itself. often worse when you flex the wrist, often worse at night, often worse with hand elevation, and in about 10% of people, symptoms can go all the way up to the mid-forearm or even the elbow. So the patient now is in my office for their visit. I'll explain to them what the nerve test means. I'll explain to them the typical symptoms of carpal tunnel syndrome that I mentioned already. I'll confirm that most of their symptoms match with that. And then I'll bring them into the exam room and I'll test their strength in their hand. I will then also do a special test to help also confirm my diagnosis, where I will actually press on their median nerve at the wrist and then bend their wrist forward. I'll hold that for a few seconds, and if doing that reproduces their symptoms, that's another good sign that they truly do have carpal tunnel. And then we'll go into their options. So let's talk a little bit about what your options are if you are diagnosed with carpal tunnel syndrome. So as with almost all of the topics that I've been talking about on this channel, neurosurgical issues, the patient typically has three options. Option one, do nothing. Ignore it, put up with it, try not to think about it. Technically, most patients, by the time they end up in my office, have tried that already and they're not interested in that, but I always bring that up as an option, so I cover all the bases. Option two is called conservative therapy, and unfortunately there are not a lot of great conservative options, meaning anything but surgery, for carpal tunnel syndrome. Option one is if they're pregnant, wait until they have the baby. Carpal tunnel syndrome symptoms will usually go away. If they are not pregnant and they've gained a lot of weight recently, I would mention to them that there is a chance that if they lose some of that weight back to their pre-symptom weight, they might be able to avoid a surgery and the carpal tunnel syndrome symptoms would go away. Another conservative option would be a splint, and this splint is basically made to keep the wrist in a neutral position, which is sort of like that, and that provides the most room in the carpal tunnel for the nerve. So if you can force the hand to be in that position and typically keep it from being flexed, that will typically help with the symptoms. The problem, though, with the splints is that you can't really use your hand while you're wearing them. So usually I recommend wearing the splint at night. And a lot of patients only have symptoms at night. So if all they have to do is wear a splint at night to avoid those symptoms and get a good night's sleep, some patients do opt for that. But over time, that tends to not work as well, and the symptoms start to occur during the day. Or if the symptoms are mostly in the patient's non-dominant hand, they could elect to wear that splint during the day and not have too much of their quality of life interfered with. So a splint is another non-surgical conservative option. There are other options like injections. I have not found those to be very effective. If the nerve is inflamed, it certainly might help with that, but an injection in the wrist around the nerve does not do anything for the amount of space that's there for that nerve, which is the primary problem. So I usually, or almost never now, recommend injections for my patients with carpal tunnel syndrome. Other than that, that's pretty much the only non-surgical options for carpal tunnel. So now let's talk a little bit about the surgery option. So if the patient has failed conservative therapies and their symptoms are bad enough, or if they're demonstrating weakness, I will usually recommend surgery at this point. The surgery for carpal tunnel syndrome is a relatively small surgery. It's probably one of the smallest, shortest surgeries I do. The patient is usually not fully asleep for this surgery. We typically give them some happy medicine, give them some forgetting medicine, and we kind of put them under sedation to the point where they're practically snoring. So they don't have a tube in their lungs, they're not under general anesthesia, what we call it when you're fully asleep, but they certainly don't remember the surgery with this kind of light sedation that I use. So I'll usually bring them into the operating room. The anesthesiologist will give them some happy medicine, some forgetting medicine. They'll kind of go off into la-la land. We will prep the hand that we're doing the surgery on with some betadine or cleansing solution, put on the sterile drapes so that just the hand is showing up. And then what I'll do is I'll make about a 1/2 inch incision slightly off to the pinky side of the hand, above the wrist crease, or what we call distal to the wrist crease. So there's the wrist crease right there. I don't like to cross the incision over the wrist crease. That I find can lead to some healing difficulties. So I usually start here and about a ½ inch to there. Now keep in mind, the ligament that I showed you on those diagrams that covers the nerve kind of goes all the way up to here and all the way down to here. So I will warn the patient that after the surgery, they may be sore down here in the wrist, even though it doesn't look like I did surgery in that area, but I really did. Because during the surgery, I kind of lift up this edge of the incision and kind of peek down that tunnel and cut the ligament all the way till where it ends. And keep in mind that one of the most common reasons for a carpal tunnel surgery to fail is because the surgeon failed to cut the ligament all the way to the end, down here. So that means there's still pinching down here that they didn't feel or see. I'll cut the ligament all the way to the edge here. Inspect the nerve, make sure it looks free. If there's any kind of adhesions or scar tissue, I'll make sure those are not pinching the nerve anymore. Wash it out and then put in about 2 or 3 stitches, which will come out about 2 weeks after the surgery in this little incision. And that whole surgery to unpinch the nerve in the carpal tunnel takes about 20-30 minutes. You'll wake up in the recovery room. Your hand will be all wrapped up with a special dressing. Your fingers will still be sticking out here, so you can use your fingers. The dressing will come down to about here. There'll be an ACE wrap around the whole hand, again with your fingers sticking out so you can still use them. And I'll want you to keep that hand elevated for the first night. So usually patients get to go home that day after surgery, but I'll instruct them to keep that arm on a couple pillows if they're in bed, or in a sling, which we will give them before they go home if they're walking around. I do put some numbing medicine in the skin before the surgery, and that usually lasts about a couple of hours. So after a few hours, it may start to throb a little bit, and they'll get pain medicine to take home with them if they need it. Not everybody does. Usually about 30-45 minutes in the recovery room, letting the anesthesia wear off. Then you'd go up to over to the holding area. Once you can eat something, drink something, and walk to the bathroom yourself, we'll let you go home. A couple days stuck in the house, and that doesn't mean lie in bed all day, but just stay home. You're allowed up and down steps, watch TV, read a book, take a nap, play on the computer, this kind of thing with your fingers. Stare out the window, watch the grass grow, that kind of thing. 3 or 4 days after the surgery, you can drive, one-handed only. So if you have a manual or stick shift car, you'd have to borrow somebody's automatic. Short trips only, the bank, the post office, the grocery store, that kind of thing. After about a week, you can increase your activities even more, but nothing strenuous, no working in the yard, no shoveling, snow, anything like that. 2 weeks after the surgery, you'll be back in the office to get your stitches out and to see me for a post-op check. I'll look your incision, I'll ask you how you're feeling, and usually what I hear is, I was sore in the wrist and the incision area for a couple of days, but all those symptoms that used to wake me up at night, that very first night after the surgery, they were gone. Dramatic, sort of turn off the light switch type improvement in symptoms. That's how soon patients typically feel improvement after releasing that nerve from that pinching. Keep in mind, if you did let this get bad enough that you had weakness, that weakness can take longer to get better. Sometimes months, sometimes even a year, and sometimes if it's been allowed to go on long enough, the weakness never really returns, or the strength never really returns. That's usually rare, and it has to get pretty bad before that'll happen, but I do warn patients about that. The other thing I warn patients is that even after the 2-week mark, it may still hurt a little bit if you press on that area. Doorknobs, grocery carts, manuals, stick shifts in cars. So I just warn people that doesn't mean something's wrong. It's normal healing, and it will be sore to pressure for a good couple of months. If the patient has carpal tunnel syndrome in both hands, I'll typically recommend that we wait 2 to 3 months for the first hand to heal up before we do the other hand. So at 2 weeks, if everything looks good, from my perspective, the patient's graduated, they're off the hook, they don't have to come back. So that's pretty much The before, during, and after the surgery for carpal tunnel syndrome. Keep in mind that there are variations on how to do this surgery. Some people do it endoscopically, which is where the incision may be half that size, but they'll use a little camera to go under the skin to find the carpal ligament that has to be cut. Some people will do a smaller incision, even though that's already pretty small, but smaller than that, and they'll put a little instrument in that has a little hook on it, and they'll hook the end of the ligament and pull, hook the end of the ligament and pull, and that will cut the ligament. I'm not necessarily a big fan of those procedures because there are two branches that come off the sides of this nerve on the thumb side of the nerve, and they can control various uses of your muscles in your hand, and I like to be able to see the nerve directly before I cut anything. It's harder to do that when you do the surgery endoscopically or with that little hook instrument. So I'm a bigger proponent of a slightly larger incision, which is still pretty small, but being able to see the nerve before you cut anything. So just because a surgeon may do it endoscopically or through a smaller incision where he doesn't actually see the nerve with his own eyes or her own eyes, that doesn't necessarily mean that is the wrong way to do it or you won't have a good outcome. Just keep that in mind. So now let's talk a little bit about the risks of the surgery. Okay, so there are 3 risks to any surgery. It doesn't matter how big or small the surgery is, same 3 risks: infection, bleeding, problems with anesthesia. Now those are all extremely low, especially for this kind of surgery, but they're in the book, so we have to tell you about them, and that's why before the surgery we'll typically get some blood tests, make sure your blood clots properly, your electrolytes are good, basically that you're healthy. Infection is a risk for anything you do, but I typically give patients some antibiotics before the surgery. We do it in a sterile operating room environment. But even though we do all those things, there's still about a 2% risk nationally that you can still get an infection. Typically, if that happens, it's a superficial skin infection, and it usually sort of takes care of itself with some extra antibiotics if that happens. Risk of bleeding, very small in this area of the body. I've just never really had an issue with that, and I've never really heard about that being an issue, but it's in the book, so we have to tell you about it. Risk of anesthesia, also low for this surgery, low compared to other surgeries because I usually don't give my patients general anesthesia, and it's a very short procedure. So the risks of anesthesia are extremely low. Now there are a couple of risks that are special to this surgery because of where it is, and that's basically because you're operating near a nerve. So injury to that nerve, which can cause numbness or tingling in the distribution of that nerve, which we've already gone over with, or weakness to the muscles that nerve innervates, which is typically the thumb moving this way. Again, a very small risk, especially if you're careful and you have a lot of experience with this surgery. And knock on wood, I've never had that risk or that complication with a patient of mine, but a risk of injury to the nerve or its branches is in the books, so I have to tell you about it. And then the last risk, which is not really a risk, is that issue I mentioned where if the ligament is not fully cut to where it ends, which is about here, you may end up having the surgery but still have the symptoms because this might be an area that was pinching the nerve. Usually it's a little higher up here, but it's always a good idea to fully cut that carpal ligament to make sure that that nerve is not going to be pinched after the patient wakes up. And those are the 4 or 5 risks to that surgery. So we talked about what carpal tunnel syndrome is, the symptoms, why it happens, your options, the surgery option, what to expect before, during, and after, and the risks. That's probably not as much detail as I could have gone into, but enough that you would probably need to kind of tide you over until you actually have your appointment with whoever your surgeon is, or at least kind of make you feel a little less anxious about the problem. The surgery to fix this is, as I said, a very small, low-risk surgery with usually a pretty high payoff. Remember, these patients typically wake up after surgery with very little pain, and the very first night they go home, they notice that they don't wake up because of that hand. So that's basically the video on carpal tunnel syndrome. I hope it helped. Don't forget to like and subscribe to the channel if you think it was worthwhile. And most importantly, don't forget, stay healthy.